patients are not having clinical symptoms of excess, why would you want to lower that? It doesn't make sense to me. All right, here is our testing on the male side. There's a lot of things that you can do, okay? A lot of different ways, urine, saliva, there's a lot of different stuff in the blood. You could go crazy and test all of it, which in the beginning, I did. I tested a lot of things. Why? Because when you, the more inexperienced you are, the more labs you tend to run, because the more it helps you to figure out what's going on. So these are now my I basically run 4 tests to really look at if I'm considering testosterone, okay? Again, when I'm running a hormone panel, if I'm also considering progesterone issues and DHEA issues, like I'm running those as well. But in terms of what I'm looking at for testosterone, I'm looking at LH, total and free T3, and if anything, I've actually more so been leaning. I know we always talk about free, but I just more so see, I make clinical decisions based off total testosterone more so than free testosterone, and then sex hormone binding globulin. So LH, the reason this matters is because it tells us the feedback loops on what's going on, because that can also direct treatment, okay? So remember, LH comes from the brain, goes down to the testes, tells the testes to make testosterone. If testosterone's low and LH is low, what we're getting is that the brain is not telling the testes to make testosterone. If LH is high, testosterone is low, the brain is screaming at the testicles to make testosterone, and they're not. The difference between those, one tells us potentially, and I still do not fully understand why in men it is not pathological, in the sense that it's not like there's a tumor or something like that, but most men come in and LH is normal and testosterone's low, and I still don't fully understand why. But we see it a lot more often, because you would think that testosterone goes low, the brain's going to respond appropriately, and it's just, in middle-aged men, it just for some reason does not seem to happen that way. So if, and we'll talk about treatments in a second, but I'll say it now. So if LH is low or normal and testosterone is low, I know that it's not necessarily, or I should say, that it is likely that the actual Leydig cells are capable of producing testosterone. They're just not being told to. So that's where things like HCG and clomiphene can be beneficial, because those increase, well, clomiphene is going to increase luteinizing hormone, and the HCG is a luteinizing hormone analog. If LH is screaming at the testicles to make testosterone and the Leydig cells are not making testosterone, doing clomiphene or HCG is inappropriate, because you're just going to scream at the testicles more and they're not going to make more. Maybe a little bit, but not a whole lot. 700 to 1,000 or 1,100 rough numbers that I look at for total testosterone. Again, in the grand scheme of things, we're looking at symptoms in relation to that. Free, 25 to 35 nanograms per deciliter. The other thing too that you'll start to come to notice is that in the old, so in the hormone world, there's 2 camps. There's the camp of, we want your hormones to be what they were when you were 20 years old, and we want that until the day you die. And then there's the camp of, we want the minimum effective dose of hormones as you age in order to not have symptoms, regardless of what the blood value is. I'm kind of in between both, in the sense that I want my patients to feel really well, so I'm okay if it's 1,100 when they're 60 years old, but also if they feel just almost as good at 600, I'm okay with that. I don't see the need to go, there's no research suggesting that taking a patient who's basically asymptomatic at 600 bring them up to 1100 has a positive benefit. Okay. Androstenediol glucuronide, arguably the best test to look at metabolic activity of DHT, which is way more potent than testosterone, and testosterone gets converted into DHT in the cells. However, I mentioned this yesterday, if insurance does not cover this, which it's pretty rare for insurance to cover it, because they look at this as a even more specialty test than total testosterone, it's about $250 through LabCorp or SonoraQuest. There's one patient that I fought with insurance to get this and got it, and it's because she had all the clinical symptoms of PCOS. DHEA was normal, testosterone was normal, androstenedione was normal, DHT was normal. Androstenediol glucuronide was clinically elevated. That gets back to receptor activity. Her levels of androgens were in excess to her despite being in the normal blood reference range, and so she was having a heightened metabolic activity causing hirsutism, acne, weight gain, and the clinical symptoms of PCOS. So in her, we actually started metformin because I want to decrease androgen activity. So one thing I forgot to mention about metformin, it does decrease testosterone a little bit, which may be fine. It may cause clinical symptoms. If it causes clinical symptoms, you can do things to help replace it, okay? So that's why I don't, even though this is the gold standard test for metabolic activity, I don't run it that often anymore, okay? And then sex hormone binding globulin comes into play because, again, if that is really, really, really elevated, it can bind up a lot of the free testosterone. And again, sometimes it's a way that we can look at intervening. Nettle root doesn't really move the needle a whole lot as much as we would love it to, okay? One of the things, interestingly, that is slightly counterintuitive, but that decreases sex hormone binding globulin is restoring normal levels of testosterone. So if total testosterone is at 500, free testosterone is at 14, sex hormone binding globulin is at 70, my approach is testosterone replacement, because increasing the testosterone to a higher level if they're symptomatic drops sex hormone binding globulin. In most patients. Some patients it still doesn't, but in most patients it does. Estrogen. I don't really look at estradiol a lot anymore in my men when I'm looking at testosterone because I don't think it's as clinically relevant. The reason why is, I'll say the one exception on when I do is when sex hormone binding globulin is really elevated, because estrogen is another way that SHBG goes high, and so I want to know if that's the potential reason why it's really, really high, if it's not responding to increasing testosterone, or if patients are having clinical symptoms of high estrogen. Gynecomastia, nipple enlargement, breast tenderness. That's the only time I start screwing around with estrogen in men and trying to drop it. It used to be, when I first learned, standard, when you do testosterone, you give an anastrozole. You give testosterone and you block that conversion to estrogen. There is a, not covered here, but there is a whole lot of research showing that estrogen in men is protective to the bones, protective to your brain, protective to your heart. If patients are not having clinical symptoms of excess, why would you want to lower that? It doesn't make sense to me. So I don't use an anastrozole anymore at all. If I have a patient and we're doing testosterone injections and their levels are nice and high and they feel good, but they start developing gynecomastia, I just decrease the testosterone dose. You decrease the testosterone dose, the estrogen goes down, and we get out of that situation where they're having clinically excessive testosterone. Where in both men and women is the biggest conversion of testosterone to estrogen? What cell? Fat.
Yeah.
So weight loss is going to be huge for patients who have also elevated levels of estrogen, which is where a lot of this research comes from, this correlation research, where they say, oh, high estrogen is related to obesity in men, so we need to decrease estrogen. No, it's the obesity that's causing the estrogen. It's not estrogen that's causing the obesity. If you're going to do estrogen in men, run a sensitive estradiol. It's also called ultra-sensitive estradiol. It's a more sensitive assay that better picks up true estradiol. When you run a basic estradiol here, there is cross-reactivity with progesterone and estrone. So it could falsely make a patient's estrogen look high. This is not really an issue in women because the percent change that occurs with a non-sensitive assay is minuscule. In postmenopausal women, it could be a big deal. So postmenopausal women and men, I run a sensitive estradiol over a regular estradiol. I included all these other ones here for you guys because you're going to have patients come in with this information as well. They're going to come in with another lab test that shows their estrone. They might have a salivary, and so if you're like, well, you can't afford more testing, you just had this test done, we just started working together, even though this is not great, let's make some inferences on what we have based on symptoms. Okay? Women. Total testosterone, free testosterone, sex hormone binding globulin, DHEA. Because again, remember, DHEA can provide a large portion of conversion to testosterone in the cells. What I don't use this for is I don't say, oh, your DHEA is low at 120 and therefore that's causing your blood testosterone to be low. Because remember, that conversion from DHEA into testosterone is occurring in the cell, not in the blood. So this is why you'll look at research, and the research shows very clearly that giving DHEA almost never changes testosterone levels. But it can hit the testosterone receptor because that DHEA goes into the cell, which we're not measuring in a blood test, and then becomes testosterone, and then testosterone exerts its effect. You guys see some glazed faces. You follow?
I'm following.
Okay.
I'm just like, this
Yeah.
is what I learned. I'm like,
Okay, so
yeah, it makes sense.
DHEA, supplementing with DHEA does not change to any significant degree testosterone blood levels. What it does change is cellular activity of testosterone, because the DHEA goes into the cell converts that into testosterone, and then testosterone hits the nuclear receptor. Going back to the whole concept of what does it actually mean to be biologically active is hitting the nuclear receptor.
How is that measured?
So you could measure that with androstenediol glucuronide if you wanted to. I just go based off clinical symptoms.
Yeah.
So if I have a patient who has, for example, low total testosterone, low DHEA, and the DHEA is real low, more so than this, and we just want to start a little conservative, I'll just start with DHEA to find out how well she's going to do with that conversion in the cell, irregardless of what happens with total testosterone values. This is why you can actually have patients with PCOS who have low total testosterone values, but really high DHEA.